with the, I've got someone who's got it's class 1 molar. He's only about 9, but his 7s are actually coming in. His lower 4's caught out, tiny little bit of crowding anteriorly. So I was going to do a 2+4.
Yep.
What wires do you use?
Well, we'll start off with the 014, 016, 014, probably 018 nitinols as a sectional wire, okay? And then we get our working wire basically is an 018 stainless steel.
Okay, so just run him in that 014 for about, what, 8 weeks?
Yeah, just the same principle. Just you get full engagement, align those teeth, but just do it as a sectional wire, 2 to 2 or 3 to 3, because if you start to take it back to the 6s, it'll just keep pulling out all the time.
All right, and then run it back to 6s when you get to an 018.
Yep, yep.
What about getting like the 4's caught between the E and the C?
The 4's. What do you mean?
I'll send you a snapshot after.
Okay, yeah, that would be great.
Yeah. All right.
Greg, can you hear me?
Yes, I can hear you. Can you hear me?
Greg? Greg, can you hear me?
I can hear you.
Okay, I can only just hear you. Greg, I'm just going to turn up. Yeah, I want to do your case after we do module 4.
Yep. No,
okay, because I think you'll get a lot more out of it then.
Yeah.
Okay, so I'm going to share my screen now. So hopefully you'll be able to see it.
Yeah.
Okay, and I'm going to show you a case that you may have seen before, but now it's going to give you hopefully a little bit more insight into the thought process. So I want to put as many people's speakers on as possible. Okay, so because I'd love to hear other people's opinions on this. So this lady came in. No great medical history. She's on the contraceptive pill. She was missing a permanent tooth when younger, and for some reason, the dentist removed the predecessor baby tooth, and she's got an underbite, as you're going to see in a second. So this is what she looks like facially. So she's pretty. Would you agree? She's pretty dolichofacial.
Yeah.
And she's got a little bit of a bimax protrusion. And she's got what I would call a long lower facial height, which would be understandable with her dolichofacial pattern. So here she is, but she's got fairly good lip competency, okay? Because a lot of these dolichofacial patients don't have good lip competency. So here we are, and you can already see in her relaxed position, her smile arc is pretty poor, and she has a big diastema between her upper centrals, and you can probably just get a little bit of a vision that she's got a little bit of an underbite. So she's definitely an Asian class 3 skeletal dolichofacial. So, and she's got a pretty typical Asian type of profile here. So I just want to see if I can unmute a few more people. But I think obviously a lot of people don't have their microphones on. Okay, so these are her intraoral photos. Now, one of the things that, as you can see, we put and I really want to reiterate this to you guys, we use that blue articulating paper on the occlusal surface of the right-hand side, because this is the only way that we can be sure of our orientation, especially when we're using mirror shots, because we get the staff to load the photos in, and if they're not right, it's not too hard initially, but when we're looking during the treatment and we're trying to figure out what do we need to do, this is really advantageous, so we know that we've got the right side that we're looking at. So I really urge you guys to start to get whoever's doing the photos to just put the articulating paper on just at the time they're doing the occlusal photographs. So, Jim, what do you see here?
Well, either class 3 or pseudo class 3.
Okay, good.
Missing upper right 4.
Yep. It's hard to know whether we're missing the upper right 4 or the upper right 5 here.
Oh, yeah.
Okay, because it could have been a bit of a little drift, and we'll get a better idea when we look at the OPG. Okay, so you said something which was really interesting just before. Class 3 or pseudo class 3. Now, this is a really interesting case because this woman saw me after seeing 4 other orthodontists. And what do you think all 4 orthodontists said?
Surgery.
Yep. As you know, I don't know whether it's the same in Tassie or anywhere else, but you know, where I am in Melbourne, as soon as somebody sees a class 3, they immediately talk about surgery. That's but what you said was the key, and the key to the diagnosis here is: are they a pseudo class 3? You know, can we get them edge to edge? Because if we can get them edge to edge, all we then need to do is to close up some of these lower spaces and retract some of the lower anterior teeth, and possibly even open up a space for the upper right 5. Because if we try to close up the upper spaces, we're going to make the reverse overjet worse, correct?
Yeah.
So in a class 3 patient, you want as much tooth structure in the upper arch as possible. That would be the key. So what are we going to do now from a diagnostic point of view?
Centric relation.
Yeah, so we want to see if we can get them into an edge-to-edge position in centric relation, which I could, and I'm going to show you that later on, okay? So let's assume that we can get them edge-to-edge in centric, and we can get them just about edge-to-edge in centric relation here, okay? So that's a picture. So we can, if we can move those lower teeth back by, say, 2 millimeters, and even move the upper teeth forwards by 1 to 2 millimeters, we should be okay. Okay, so this is I think a really interesting case here. So here we are, big diastema, and this is where I could actually get them in centric relation. Okay, so what I'm saying to myself is, can I move those lower teeth back? And I've got spaces. Now, if I had crowding here of the lower teeth, that would be a whole different ballgame, wouldn't it? Because if I had crowding of the lower teeth, then any alignment of those lower teeth would actually move the lower anterior teeth further forwards and aggravate our class 3 situation. And we may need to consider possibly some dental extractions in the lower arch if we were going to look at treating them non-surgically. Correct?
Yeah.
What would be our caveat on that? In other words, when would we decide that we couldn't do what we would call a camouflage treatment here? In other words, what would say to us, I don't want to take out any lower teeth? What indication would you see clinically that would get you to say, I don't want to take out lower teeth?
They're really retrude.
Exactly. So if they were really retruded, retroclined, any extractions, and even in a spacing situation, no different. Yeah, the more spaces you've got, the more they're going to dump backwards. And in fact, the retrocline lower incisor situation is really is nature's way to compensate for a severe class 3. And that's what I tell my patients, is that if the teeth are tipped backwards, it's nature's way to try and say, hey, I want the lower teeth behind the upper teeth. So it's a dental compensation, and as soon as you put your brackets on, you're going to actually remove the compensations. So we did a Ceph for her, but the funny part about it is, as soon as you do a Ceph, right, what's the Ceph going to show?
The skeletal relationship.
Yeah, but what's it going to? If I did a Ceph on this patient, and I've got a Ceph, but unfortunately I didn't find it for the presentation, what would it tell me? Would it tell me they're class 1, class 2, or class 3?
Class 3.
Yeah. So because we're taking that Ceph in a postured position, so it's not a true indication. So when you hear of orthodontist surgeons go, well, I did the lateral ceph and it showed me that there was an A and B, a negative of 4 degrees, that obviously it will be because you're taking eccentric occlusion. So how, if you really wanted to do this diagnosis properly from a lateral ceph, what would you do?
Do 2 cephs.
Yep, okay. And how would you do the 2 cephs?
You just make sure they're postured at CR.
And how do you do that when you're going to when you're probably sending it to a radiologist who's got no idea what you're talking about?
Yeah, I don't know.
Okay, so what you would do as a dentist is you would do a wax bite for them in centric relation, and you tell them that you want 1 ceph taken normally, like they have in centric occlusion here, and then the other ceph to be taken with the wax bite in place.
Mm-hmm.
Does that make sense?
Yep.
Now, the problem with that is that the one with the wax bite is going to show a far more open vertical situation. So you would do your ceph analysis from the sagittal perspective with your wax bite in place, and from the vertical perspective, you would do it in centric occlusion. So you would use different you would take the different measurements from the 2 different cephs. Would that make sense?
Yeah.
So from a diagnostic point of view, okay. Now, a dolichofacial class 3, right, is a great patient, okay, because as I open up the vertical, what's going to happen?
I'm class 3. Class 1.
Yeah. Now, the converse is true. A open bite class 3 is terrible, because then I'm going to have to rotate the mandible down further and I'm going to aggravate the vertical. So class 3 with a deep bite is a much easier case to treat than a class 3 with an open bite. Does that make sense?
Mm-hmm.
Because as soon as I try to reduce the lower facial height by intrusion of the posteriors, whatever it be, to close the vertical, I'm actually going to aggravate the class 3. So a class 3 with a deep bite is a much easier case and better case to treat than a class 3 with an open bite. Okay? So far, so good?
Mm-hmm.
Okay. So here we are now. So we've got them into an each tension position, and we're basically going to say, hey, we're going to treat this patient non-surgically. Okay? And we're going to retract the lower anterior teeth, and we're going to open up the space for that missing upper right premolar. Okay, correct?
Mm-hmm.
Okay, so, and we've got a big diastema here as well. Okay, so our diagnostic summary would go as follows, okay? And the main thing being, we've got a pseudo class 3 and we've got a COCR shift on the upper central incisors with the lower central incisors. And as a result, we've got a negative 3 millimeter overjet with an associated anterior crossbite, okay? And fortunately, from our lower incisors are slightly advanced, so we can afford to bring them back a little bit, okay? And from the OPG that we haven't got in there, the 1-4 tooth has tipped severely distally, and the root is very close to the 1-3, okay? We've got increased lower facial height, so everything else is pretty straightforward, okay? So we've got a lot of spacing in the upper arch, and we're missing the 1-5. We've got this large diastema. So firstly, when you see that large diastema, what are we thinking here? What's your thought process?
Big frenum.
Yep, frenum, yep. Greg, what do you reckon here?
Well, to close it, you'd generally be moving the teeth backwards, which you don't want to do.
Well, that's right. Okay, that's if we were closing it totally. Okay, okay.
What's the dimensions? Because they look a little bit longer to width on the photos.
What do you mean they look a little bit longer?
Oh, just the length of the crown. Oh, maybe not. If anything, they look a little bit shorter.
Exactly. Yep.
So, you know, at the end, maybe some cosmetic build-ups.
Yep. Possibly. Yep. Going back to what you said, it's so true. If we just close up those upper spaces, we're going to pull back the lower teeth, the upper teeth, and that's the reason why I want to open the space here for that missing 5. I want to try and push all these teeth as far forwards as I can and close the diastema as much as possible by movement of the posterior segments forwards in this case, rather than just closing up the space without any consideration for the reverse overjet. But what else do you need to consider as part of your ultimate treatment plan? Would you like to say something? Feel free to. Because remember, in your treatment plan, you've also got to plan retention here as well. So what would you be doing as part of your retention therapy for this patient? The patient's come in and I'm assuming one of her chief complaints is I've got that big gap between my upper central incisors. So what's the last thing you want to do? Is allow that gap to open up again.
You'd have to bond some wire behind it.
Absolutely. So we've got to plan that from day one. Because what happens, and trust me, it's happened to me not once or twice, but probably 100 times, okay, is 2 years down the track, you forget where they first started. And you keep on having to re-treatment plan the patient. So at this particular stage, as you look at this patient, you want to plan your retention as well. Otherwise, you keep going back every time and you spend so much more time re-treatment planning the patient. So at this particular point, you're going to go, okay, I'm going to plan for my retention and upper bonded wire as well. I'm going to do everything I can. Okay. So here we are. That's our diagnostic summary, which is all pretty straightforward. We've got spacing in the upper arch, we've got spacing in the lower arch, etc. Okay. And we need to improve the smile arc. We need to actually extrude those anterior teeth a little bit. And basically, as Greg was saying, there's actually a poor height to width ratio on those upper anterior teeth. So we might need to do some crown lengthening, we might need to do some cosmetic work, etc. And it turned out that the upper laterals were just a little bit small compared to the upper centrals. Okay, and so if we go back here, one of the things to try and restore that Bolton discrepancy here is to maybe to build up some of these anterior teeth as well to help close up some of these spaces. Okay. Okay. So let's go down because because now I think so our non-surgical approach would be to open the space. We're going to do upper and lower fixed appliances, okay, and we're going to power chain the lower arch and class 3 elastic. And now a couple of things. How do we extrude those upper anterior teeth? Because we need to extrude those teeth, correct?
Yeah.
Okay. How are we going to extrude those anterior teeth?
An open bite setup, Jeff?
Yep. Great. Okay. So tell me, Greg, day one, how are you going to put the braces on day one?
Or what you've got there, put the I want bite turbos on to unlock the bite, so allow things to retract.
Yep.
And you can. Oh, as far as I know, you could put the from what I can see, put the braces on day one. But I'm a little bit unsure about having upper, as you say, with braces, generally move everything outwards.
Unless there's spacing.
Yeah, so
And we've got spacing here.
Yeah, so I'm a little bit unsure. Would you be looking at an open spring coils from the sixes, pushing the 4 forward and forgetting about the upper front teeth initially?
Okay. Manita just said, Jeff, would you start with the lower treatment first? Okay. And because firstly, as soon as we put our brackets on, okay, and we've got an open bite setup, how can the upper anterior teeth extrude whilst you're in an edge-to-edge bite? Yeah, that's what we call a constraint in the system. And if the upper anterior teeth don't extrude, what's going to happen to the other teeth? Because if you've got an open bite set up there, Greg, okay, the wire's going to deflect into those brackets, okay, and there's going to be an extrusive force on those upper incisors, correct? If those upper incisors can't extrude, what do you think is going to happen to the adjacent teeth?
Intrude.
So, okay, so the key, and this is the fallacy where people go, okay, we're going to put the upper and lower braces on, and we're going to do the open bite setup, and you're totally correct. We have to do an open bite setup here, but the question is the timing of it. So what we want to try and do is reduce all of our risks. So the first thing we want to do is try and get the lower teeth back as quickly as possible. Okay, put the bite turbos on, start to retract the lower teeth, get some overjet, and then once we've got that, we go ahead and put the upper braces on. Does that make sense?
Yeah.
Okay, I'll remember that.
You remember that?
I'm going to have to go.
Okay, it's going to all be recorded.
Oh, fantastic.
Okay, so the other option is we could have closed the space for the 1.5, but if we do that, we're now going to do exactly what you're talking about, Greg, is we're going to bring, if we start to close the spaces, we're going to retract the upper anterior teeth and we're going to make the class 3 worse. And then they're going to definitely need surgery. So if this patient did not want an implant or prosthetic replacement of that missing upper right 5, they need to have surgery. There's no doubt about that. But if they go ahead and have an implant or a Maryland bridge or a conventional bridge, however you want to restore that tooth, we can do this without surgery. Okay? So the mechanotherapy will be, we need to correct our critical path to success is correcting that functional shift. That's our critical path to success. So here, what we did, we placed the open coil spring. Okay, we're going to use self-ligation brackets. We're going to do bite turbos, but we're going to power chain the lower 3 to 3 initially, and we're going to wear early class 3 elastics because I want to get those lower anterior teeth back as quickly as I can. So in some ways, I could have bypassed the upper anteriors. The sooner I can get the lower anterior teeth back to a proper overbite, overjet, then the better all of my mechanics is going to work on the upper arch. That's really the key. So we need to wear these class 3 elastics very early. You know, the POS guys, they get told, don't wear elastics till you're in the heavy wires. We need to do this day one. The sooner we can get those lower anterior teeth back, the better. Okay? And we're going to talk all about the different types of torque brackets and all that type of stuff in some of the other modules. But the key here, and that's really just icing on the cake, because the key here is getting the lower anterior teeth back, and we want to power chain from the lower 3 to 3. And here I've said we're going to power chain from the lower 4 lingual to the lingual of the 3-4. So if we go back to the original photos, I'll show you what I mean by that. And if you don't do it, you're not doing anything wrong either, I might add, okay? But I want to show you the original photos, the occlusal view. Okay, so here in the occlusal view, can you see how your 4s are rotated mesial to the lingual? So what I'm suggesting is we put a button on the lingual of the 4 here, and we run our power chain all the way around to the lingual of this other 4. So what we're actually doing now is we've got the spaces here, we're closing those up, and we're also rotating these teeth as well. You could have done it from the lingual of the 5 as well if you wanted to, because that would have helped the rotation, but it's probably just easier to get the button on the 4, because all we want to do is use this space here to retract those lower anterior teeth as quickly as possible. Does that make sense?
Mm-hmm.
So all I'm trying to do is just give you better ways to treat the patient in the quickest, most efficient manner, because there are many ways that you could do this. Okay, there's not one right way. Okay, there are many right ways to do it. Okay, and we're going to need to build up the upper laterals. The risk assessment is the dolichofacial tendency with the bite opening, but honestly, because of the spaces that you've got in the lower arch, I think we can control that, and we can control that pretty well with our posterior bite turbos. Okay, and we've got to make sure that we have the good root position at the end if we're going to place an implant in the 1.5 region. So the problem there is that when we put our power chain on, we've got to be very careful with the rotations that are going to occur. Sorry, when we put our open coil spring in, we've got to be very careful with the rotation here on the 1.4 as well. Okay, so that's what we've got to watch for during our treatment. And our compliance problem is the patient wearing class 3 elastics. So we've got a non-surgical approach, we've got a surgical approach, and obviously, if it was you or a family member, you'd go for the non-surgical approach, okay, with 1 implant.
Oh, it's actually really good.
So, is that a question?
No, mate, it's just staff in the background.
Okay. So we actually did a whole simulation, and in one of the modules, I really want to go through how do you do these simulations, because you'll get a lot of information out of them. Okay, but suffice to say, we did simulations of all the different options. Okay, so posterior bite turbos are the key, and we want to open the space for the 1.5. That's our key. So let's go through and see what we did. Okay, so our checklist to monitor our progress. We want, before we start to even consider closure of the upper spaces with any type of power chain. So to start off with, our upper space closure will be purely with bringing the anterior teeth, the upper right posterior segment forwards. We're not going to put any power chain or do anything on the upper anteriors that could cause any retraction of those teeth until we've got at least a 3 millimeter overjet. Okay, so that's really important, because if you start to put power chain on the upper arch early on, you're just going to be chasing yourself all the way through. Okay, so our checklist to monitor our progress is don't do any anterior space closure with conventional power chain or conventional mechanics until we have a 3 millimeter overjet. And another checklist is we want to get a class 1 canine relationship. To be honest, that's our checklist in probably 95% of patients. Okay, we've got to look for the class 1 canine relationship. And remember, the 4.5 and 3.5 are quite rotated, so we're going to start with some power. We're going to start with some power chain. That should be from the 4.6 to the 4.5 and the 3.6 to the 3.5. Okay. So in our retention, we're going to do a bonded upper 2 to 2, lower bonded 3 to 3, upper Essex at night, and then we're going to do a final implant. Okay. But prior to that final implant, we need to make sure that we maintain that space, because that patient may not have an implant for 2-3 years later. So these are all the things that we want to look at, and we want to monitor. And our potential side effect could be the root proximity issues in that 1.5. That's something we've really got to look at during the treatment to make sure we will have enough room for an implant, both coronally and between the roots. And for me, it's a bit different to you guys, but for me, I'm going to reevaluate that patient and send them back to the restorative dentist at least 3 months before I deband the patient for the assessment of the implant. Because if I say, oh, I think I'm ready now, and I deband the patient, and you guys say, hold it, there's not enough space there for me to do the implant, I don't want to put them back into braces again. So we've got to plan this beforehand. So here we are. So I didn't do this very well because what Manita said was so correct. I should have started off with lower braces first, but I actually put the upper brace on. But fortunately, what I didn't do, okay, was I didn't put any power chain on the upper arch. Okay, so I didn't put any power chain on the upper arch. Okay. So Becky's asked, with the Pontic for an implant, is that usually an acrylic denture tooth? To be honest, if it was in the posterior segment, I would just bond a wire. Okay, I would just bond a wire. I wouldn't even put a tooth in there. Okay, if it was an anterior tooth, that's obviously different, and I would be doing an acrylic Pontic tooth. Okay. So here we are, and this is our double 14 night high that I'm going to be talking to you about in more detail in module 4, something that we do routinely in our practice. Okay, and there is a lot of scientific basis for it, which nobody understands. But so we put the brackets on, we're aligning the teeth, and you can see we've got a little bit of tubing in here, and that's only to stop the wire from rubbing again with the patient. Okay, we find that when you've got big spaces, that wire can actually really dig in and hurt the patient. So then we went ahead and put the lower braces on, and we did the power chains, okay? And we've got the bite turbos on, and we've got the open coil spring. So now we've got the coil spring that's going to be pushing this tooth, the 4 forwards, okay? Now, sorry, that's the 5. So the 4, actually that's a 4. So we're going to push the 4 forward. Remember, the root of the 4 is right next to the 3. So we just have to tip that 4 across. So we don't have to bodily move it as much as what you think. However, what's our concern here?
The rotation created.
The rotation created. So how may you control that rotation?
Bit of power chain.
And where would you put the power chain?
From the palatal of it, I guess,
yep,
to the canine. Can you go across the canine?
Yep. So what you may end up doing is you would put the button on the lingual here and run a power chain wherever you want, wherever you need to. Okay, but you don't want to do that until we've got that 3 millimeters of overjet, because now we're going to be closing those upper spaces. Okay, so we've got to get the lower arch back into a positive overjet situation before we could ever consider putting power chain around here that would be conventional and start to actually cause some retraction of the upper anterior teeth. Does that make sense?
Yeah. If you just ran it to that upper right central, with that's obviously going to open the space a bit more, but would that give you a bit more controlled movement of that 4?
Yeah, it would, but then but you're right, you've got the downside, you're going to open up the space further. And the other problem is that upper right central is already tipped distally.
Okay.
Okay, so you do that, and now you're just going to add another couple of months of treatment time fixing up the problem that you've just created.
Okay.
Okay.
So you just live with the rotation.
You monitor it. But did you notice when I put the bracket on? Did you notice what I did when I put the bracket on?
Yeah, it's way mesial on that.
Way mesial, because I knew this, because I was factoring this in from day one. I knew this was going to be the issue. So in my bracket placement, I placed that bracket far more mesial to try and counteract those problems. But can you see? Can you see the thought process in the planning?
Yeah, yeah.
Yeah, and how it's going to save you so much more time. And here on the lower arch is exactly what we did, where we put the power chain from the lingual of the lower 4 all the way around, and with the class 3 elastics, in 3 months we were able to get a positive overjet. So here we are, probably now 5 to 6 months in treatment, and look at how much of that upper space is closed up. I've put no power chain on. I'm just pushing the anterior teeth forward or the posterior teeth forwards. But once I get my 3 millimeters of overjet, then I'm going to go ahead and put power chain on, and that's when if I needed to, I could put the lingual button on that floor now and run the power chain around. Okay. But what's interesting is on this left-hand side, this patient was a class 3, remember? What's interesting is that the patient now has developed a class 2 tendency on the left-hand side. So you might need to run some class 2 elastics on this left-hand side later on. And that'll probably help to correct the midline as well. So you'll move the upper midline a little bit to the left and the lower midline a little bit to the right. Okay? But you notice how the lower incisors are tipping back a little bit? So even though they were a bit flared forward when we first started, because of all the spaces, they've actually tipped back a little bit. So later on, I'm going to need some more torque control and use rectangular wires, because I'd be doing this at the moment on a round stainless steel wire, because I just want to get these spaces closed and get rid of this functional shift.
And how do you close those midlines? How do you move the midlines? I mean,
the midlines I'd be using, I would be going, and we're going to do this more in module 4 with my elastics.
Class 2.
I'll use some class 2 on this on the left side, and I'm probably going to even use some class 3s on the right side, because that canine is a little bit class 3.
Okay.
And that's why looking at the canine relationship is so important, because once you start to look at those, you start to realise how do you use those elastics early on in treatment. Don't look at the molars, just look at where the canines are, and that's going to move everything across. Some people use diagonal elastics. We'll talk about that in module 4. I very, very, very rarely use diagonal elastics.
You get a cant, yeah.
Exactly right, but I want to go through the biomechanics with you so you fully understand what's going on, and that's what we're going to do in module 4. Okay?
And what about correcting your overjet? If you've got 3 millimeters of overjet, will that just, the rectangular wire will correct that, will it?
Yeah, well, you'll get a bit more torque, yeah. But with a patient who was a class 3 to start off with, I'd be happy to leave them with a bit more overjet than the average person. Do you remember in module 3 we talked about the class 3 patients? They actually grow more in the mandible than the normal class 1 patient. So with a class 3 patient, I'm happy to leave them with a little bit more overjet to allow for just a little bit more mandibular growth to occur.
She's dolicho though, so she's probably going to be a vertical grower.
Probably, but I'm not fussed if I leave her with 2 or 3 millimeters of overjet. I'd rather do that, close up a diastema, avoid surgery, you know. So you're right, she's dolicho, but that doesn't mean she can't still, start. She's not 100% dolicho. She's not growing totally vertically. Yeah, she's probably going to have more vertical growth than sagittal growth. That's the other thing. But with a rectangular wire, we should correct most of that torque. So here we are with rectangular wires in place, and we're closing up the spaces. Yeah, it's at this point that I can go ahead and power chain and close up the remaining spaces. Okay, but I should be using more class 2 elastics on that left-hand side now. The right side is more class 1, so I would just probably use unilateral class 2 elastics now and close up. But once again, we've got a little bit of space here on that lower right side, so hopefully as I close that space up, I'm going to correct the midlines a little bit more. But yeah, remember where this patient is right now. Do you ever think that she would come and have orthodontic treatment? Okay, that's what. Yeah, sometimes we forget, and that's what and from a marketing point of view, especially when we do Smilefast and all that type of stuff. Yeah, you've got to manage the patient's expectations. And one of the things I think is important is you reiterate to the patient during the treatment, you go, hey, if you look like this when we first started, would you have ever had orthodontic treatment? And they go, no, we would never have had orthodontic treatment. And I think that's really important to keep on telling the patients, because they'll be a lot happier that way. So for some reason, I couldn't close the last bit of remaining space, so I put in a closing loop arch wire, which is what we're going to talk about. One of the things we're going to talk about in our module 4, different ways to close spaces. This is a great way to close spaces because it always works, okay? But I use this as a last resort, as you're going to see in module 4, okay? So different closing loop arch wires, we close the spaces. Center lines aren't absolutely perfect, okay? But you know why they're probably not perfect? Because the one thing we didn't do was we didn't build up the upper laterals. Okay, so if we'd done the restorative work, that would have actually probably moved the upper center line around a little bit. But anyway, we didn't do it. So here we are with the OPG, and you can see good root positioning now for the implant in the 1.5 area.
That's nice.
So here we are, and we're just about to finish up now. So this was about, I think, 21 months of treatment. Nice profile. She's still dolichofacial, okay? But her profile hasn't changed at all. And now you could go ahead and do your crown lengthening and whatever you needed to do. And what does stupid Jeff do or not do? I haven't put a bonded wire on. And that's what I should do. And look at how good this bone is. Would that be nice to put an implant in now? Because what we did was we moved a tooth which was into a different space, and the bone that was in this area is now the perfect bone. You could actually, remember, if you extrude a tooth, what happens? The bone comes down with it. If you move a tooth mesiodistally, the bone will follow as well. So you can use a lot of this, and we're going to talk about this in Module 8, about growing bone and doing different things for restorative dentistry. You know where you're missing your lower fives? Have you had cases where you're missing your lower fives? You could actually, instead of putting an implant in the 5 region where there's no bone, you can distalize the 4 back. And by doing that, you've now got your good bone in the 4 area. So we're going to show you all these different tricks that you can do, okay? But I think that's not a bad result for that 21 months of treatment. Done non-surgically, and we've opened up a space for an implant. But the key here was we've got to retract the lower anterior teeth and early class 3 elastics to do so. And the diagnostic key was it was a pseudo class 3. If it was a full-on class 3 with no functional shift, I wouldn't have tackled it like that.
It's a nice result, man.
Sorry?
It's a nice result.
Isn't it? Yeah, I think so. And the question is, for retention, would you include the 1.4 as well? Look, that's a very good point. I just suggested upper 2 to 2. I find it really difficult personally to put bonded wires on the 4s in the upper. Yeah, whenever you're going around this very, very curved surface, I just find it difficult. But in all honesty, what you could do, and I think it's a really good point, rather than putting it on the palatal, just lay it over the occlusal of the upper 4. That would actually be a really good thing to do. And that way you're holding the space to stop that tooth from drifting back. But you still can have a tendency, Benita, for the 6 to drift forward. So I would still put a thick bonded wire from the 6 down to the labial of that 4. But I think your idea of putting your lingual bonded wire that extends to the 4, the upper right 4, is a really good idea.
Wouldn't it just make like a Hawley appliance, the old-fashioned retention thing with a tooth on it?
Oh, now that's a really good question. No. Look, that's what people do. The problem is if they stop wearing it. Okay, if they stop wearing it for a week and the tooth drifts, you can't get it back in, and it's a nightmare.
Okay.
It's a real nightmare. Okay. So if you put a wire and you stepped it down, so it's not in the occlusion at all. Okay. That's the first thing you need to do, because otherwise you'll get hard food that will actually distort the wire. But what you could do, if the patient's really concerned, okay, if the patient's really concerned about appearance back here of the gap, just make an upper Essex as well, okay, that they can wear during the daytime, and the Essex with a pontic tooth in there.
Mm-hmm.
That's probably more comfortable than using a Hawley. The problem with a Hawley, and I have to give you that retention lecture, is the Hawley is probably the worst retainer that you're ever going to find. Okay, because the Hawley works with a 1-point contact on every tooth, doesn't it?
Mm.
So what stops the tooth from rotating with a Hawley? Nothing. There's just that 1-point contact. The Hawley doesn't go and is passive around every part of the tooth. And that's a problem with the Hawley retainer. And the patients don't wear it. And then the other problem with the Hawley, for example, in this case, when you say, because it's a good question, Jim, when you say the conventional Hawley, are you talking about with a labial bow 3 to 3?
Yeah.
That's the worst thing you can do here. Because do you remember the old days you used to make those flipper dentures for one tooth?
Yeah.
What would happen? What happens to them? They sink into the gum, don't they?
Mm-hmm.
And this is what happens with a Hawley. If you put a labial bow between your 3 and the 4 here, that space will open up. Yeah, it's this fallacy again. In extraction cases, the last thing you want is your labial bow to be between 3 and say the 5, because you've taken out the 4. Now, what you can do is you can do a labial bow that is soldered onto your cribs, onto your 6s. So there's no loop there, but it's just soldered straight across.
Okay. Yeah.
Okay, but not with a loop in between.
Mm-hmm.
Okay, but that's the. Remember, I think I told you module 1. Yeah, why do people do things? Because they got taught how to do it that way, and somebody taught them, and somebody taught them. And you've got to question yourself each and every day. Why do you do that? So labial bow between the 3 and the 4 in an extraction case is the worst thing you can do, because that's where your space is going to open up. So if you wanted to do a labial bow, like I said, which is soldered, just a straight labial bow, you can put a little adjustment loop back here if you wanted to, but not between your 3 and the 4. Have you learned something, Jim?
I have, mate. Yeah. Look, I've got to head off today, Serge, mate.
That's fine. Well, we're going to finish up. Just so long as you're getting something out of these sessions, that's all I care about.
No, really good.
Perfect.
I'll send you those photos at lunchtime when I get back, if that's okay.
That'll be great. I've got a pretty busy day with meetings, but I'll get to it tomorrow morning for you if I don't do it tonight.
Okay.
Thanks,
Mate.
We're going to see you in Adelaide, aren't we? By the way, next week, guys, there is no session because I'm lecturing in Adelaide. The week after, we've got a session, okay? And James, Jim, we're going to see you next week.
Yeah, we'll see you on Wednesday, mate. Yep, that'll be good.
Look forward to seeing all you, either in Adelaide or Sydney.
Okay, mate.
Speak to you later.
Bye.
Bye.